Hey everyone, welcome to another AASPT podcast. Today we are going to learn and talk all about hamstrings. Again, today is all about hamstrings. Megs, why don't you introduce our wonderful guest today?
Yeah, so today we're going to be talking to Dr. Steph Lazarczuk, all the way from the UK, not Kentucky, to be confused, the real UK, United Kingdom. If I'm correct, you just finished up your PhD looking at hamstring tendon adaptation. And if you want to tell us a little bit more about yourself and sort of how you ended up maybe looking at hamstring tendon, kind of where you are at now.
Sure. So in the UK, my title, my trade is as a sport rehabilitator, which is kind of the equivalent of an athletic trainer. And luckily our governing bodies have now aligned a little bit as well. So that's a good thing on that front. So I graduated from St. Mary's with my undergrad way back in 2010, which feels like a long time ago now. I then did a master's in strength and conditioning, and I then moved a bit more along the research side of things, where I did another research-based master's, which was looking at kicking injuries and mechanics in rugby union. And then off the back of that, I started to shift thought process a little bit towards PhD when I was working in academia. And kind of the reason I ended up thinking about hamstrings in the first place was that I was working clinically as well. So in my trade, like I say, as that AT equivalent, I'd worked across the original football, soccer, across rugby, cricket. I was working in ice hockey as well. And obviously most of those sports have hamstring injuries up there as being one of the number one injuries. So I was seeing plenty of them. And when I started thinking about PhD, it was around about the time when a lot of the sort of Nordic-based papers started coming through around that sort of 2016 kind of mark. And it seemed interesting. It caught my attention. You go to a few conferences. I heard someone stand up and make a comment about, oh, well, we've made the muscle stronger, but we haven't. Now we're making the tendon more at risk. And that just intuitively didn't quite make sense to me, because it's not like you take the muscle out, work it, and then shove it back in. The tendons had load as well. So what happens to the tendon? And nobody really had a good answer at that point. So we put together the PhD proposal, found a team to work with, and then away we went with some COVID modifications along the way.
Yeah, I have some questions too, if we're going to dive into hamstring. I do a lot of ACL research, so we look a lot at the quad. The hamstring is like the forgotten friend, I guess, in my world. But yeah, I do see a lot of debate amongst people within the strength and conditioning, rehab community about hamstrings. And it was thought for a long time that the Nordic hamstring curl was like the end-all be-all for how we prevent hamstring injuries. And I think one of the most difficult things with research is figuring out, like, how do we prevent injuries? And I'm not sure there's an answer to that, but I'm just sort of curious, like, based off of your work that you've done, is there anything that you have strong opinions on how is maybe the best way to condition people or condition the hamstrings to try to prevent injuries on the front end? Or maybe how's your opinion changed on that once you started your PhD?
Yeah, so the debate around the Nordic is always interesting, because depending on who you've listened to talk about it, seems to shape people's opinions quite heavily. So as an example, I've been in situations where people are saying, you know, the Australian group, there's the Nordic is the only thing that you should be doing, and there's this massive push. But actually, if you listen to those guys talk, they will always talk to you about a fully rounded program and exposure to high-speed running and progressive overload, and it's very sensible. So from that perspective, I use Nordics. I will program them. It depends on the person. If somebody's comfortable doing them, and I mean comfortable in the sense of they can kneel and it's okay, then why not? Let's go for it if it works for that person. But equally, I think the important thing, and I guess this is where the strong opinion maybe comes in, is that it's the adaptation that you're looking for that is the most important thing, not the choice of exercise. The choice of exercise comes right at the back end. you choose the adaptation that you want, you figure out what stimulus you need and what training variables you require in order to get that adaptation, and then you choose an exercise that delivers the stimulus. So if I want a really heavy, overloaded exercise that's maybe knee dominant, then yeah, I'm probably going to go for a Nordic. If I'm more interested in loading from the hip end and I want that hip extension happening, RDL, why not? So the exercise, I don't think, is the important aspect there. It's the how are you programming for the adaptation that you want. And I guess you can apply that theory to just about everywhere within the body. Interesting you mentioned about the ACL side of things as well. Obviously, being on the hamstring side of the fence, I'm obviously not thrilled at the use of semitendinosus grafts, given what that happens off the back of that. So, I think there's always debate around that as well. And I've had conversations with athletes across the years.
Do you guys see a lot of hamstring grafts over there for ACL? Over here, it's sort of shift to, I'd say our surgeons currently do, like, at least where I am, like 90% patellar tendon. And then quad tendons starting to come up, which is a whole different issue. Because, they're messing with my quad. But
yeah.
Do you guys see more hamstring type grafts over in the UK?
We did for a long while. It kind of went from that bone patellar tendon bones through to, here's a nice, easy, accessible tendon that we can get. It's local and we don't have to go anywhere else through the body. And then we started to realize, that probably doesn't make sense to rip that one out either, on account of the fact that that's a stabilizer of anterior translation. And if you want to try and reduce that for your ACL grafts, then removing one of its
helpers,
is maybe not the best thought process. So I think a lot of the surgeons have gone back towards patellar tendon now. And anecdotally, I think they work a little bit better as well. I think I've probably seen fewer re-ruptures off the back of those than some of the semitendinosus or gracilis-based grafts. So, that's a whole other debate, I guess.
Ebbs and flows with the times where they decide to go with the grafts. But I was reading your most recent paper looking at the tendon adaptation between the hip extension exercise and the Nordic. And I thought it was really interesting. It seemed like you found maybe changes in muscle size, but maybe not as much of a change in the tendon, which you were talking about how that could maybe actually increase risk of injury if you have that ratio off of muscle size to aponeurosis size, which I think is really interesting to think about if we're programming these things to help prevent injury. And there's a potential that it's actually doing the opposite if we're putting people at higher risk. I'm just sort of curious, of, were you surprised by those findings or what are your thoughts behind that?
Somewhat surprised. So the whole background behind that, I guess, is that quite a while ago now, I think around sort of 2012, 2014, there were some modeling based papers that came out that suggested that if you decrease the width of the proximal aponeurosis within biceps fem, that it increases the amount of strain that is occurring in the muscle tissue adjacent to that tendon, which makes sense, right? Just from a mathematical perspective, if you make something smaller in a tissue perspective, then it's going to change how the load is being distributed. That's obviously a fairly simplistic measure, though. And obviously, we're only thinking about this at the moment from a geometric perspective. We're sort of spectacularly ignoring the fact that there's all these mechanical properties within tendons that are also going to change with training. So in our paper, it was a secondary analysis of one of Matt Bourne's previous papers, which people might be familiar with, which was around the use of the Nordic versus the hip extension and what that does for muscle tissue. So in order to have corresponding tendon tissue, we basically went back through and did a secondary analysis of all of those MRIs, and that's where the data came from. But we found very limited adaptation. I think the only tendons associated with a muscle that were actually had any increase at all was semimembranosus in the proximal tendon. But the problem was that the error of the measurement was greater than the amount of change that we saw. So we can't necessarily be confident. There was another paper that came out also last year from a separate group who did a slightly longer intervention and did find an increase in the geometry of the hamstring tendons. So it might just be that there's a bit of a discrepancy there as well, where Matt's intervention was 10 weeks, their intervention was 12 weeks. We know that geometric change in tendons takes quite a long time anyway. So there's potential for that sort of time factor there, where I think my opinion, I don't necessarily have hard evidence to back this one up, but my opinion based on everything that I've read and seen is that, yeah, we make these adaptations within the muscle first. It's a much more pliable tissue. You get that adaptation. And then I think the tendon seems to maybe catch up a little bit further down the line. So if we are increasing our risk of injury at all, it's probably in that kind of window between muscle and tendon adaptation. But obviously, as I said, with the caveat of we're ignoring all these things like stiffness and modulus and all of these other properties that are also important. And on that side of things, we also know that those adapt faster than the geometry of tendons as well. So where we're obviously doing an MRI-based study, we're not able to capture those. So it's possible that there would have been differences in things like stiffness that might then alter how you get that sort of stress and strain being distributed. We can't say. That's definitely an avenue for future research. If anybody wants to pick that up, it's quite a difficult one. We've been trying to work out how to do it for a little bit of time now, and there's a lot of hurdles that you've got to get past for that one. But it would be interesting.
What exercises were they doing in the most recent study that came out that was 12 weeks?
They were looking at the effect of like a accentuated eccentric in a longer position. So kind of sat on a leg curl and in that outer range. So they were already, that muscle tendon unit was in that lengthened position. Yeah. And then they were able to load eccentrically as well. So I guess the difference there is in the, I guess the longest position that we would have been in the hip extension, but then that's also concentric and eccentric. So are you really overloading the eccentric if you're able to produce the concentric and come back up for debate? So there's probably a little bit of difference there as well. So
Yeah. And you have a prior research paper that talks more specifically, the meta-analysis of tendon adaptation that looks at strain percentage. So like you were saying earlier, what we really care about when we're looking for adaptations of different tissues is like with tendons, strain percentage, which we can manipulate with range of motion, load, things like that. So I think people who have been more reading the recent research have seen like eccentric, concentric, isometric doesn't really matter for tendon. It's more the amount you're straining it. So feasibly, well, potentially, depending on the individual and how trained they are, you might get enough strain with a concentric eccentric movement, as long as that contraction duration is long enough as well and not too fast. Which, I mean, that just messes everything. But I thought your research papers have individual data points, which was really nice to see. And I know Megan likes seeing individual participant adaptations because it's so different. I mean, person to person in a recreational athlete, which is, Yeah.
And I'm thinking too, you're talking about, it may take up to 12 weeks to see these tendon adaptations. So as far as say you are working with a team, say either American football, European football, any of the sort, if we're thinking about like off-season or in-season type training, and sort of what the minimal effective dose would be for somebody to try to prevent these injuries. Because sometimes you'll be like, okay, we did 2 weeks of preseason hamstring loading and we didn't see any change. So like as far as times per week, do you think this is something that should be incorporated like preseason, in season, or do you have any sort of opinions on how this might be integrated into a team setting?
For tendons, it's definitely about the consistency of the loading, right? So all time points are appropriate, I would say. Obviously, getting athletes, depending on the athletes you're working on, getting them to do things in the off season is sometimes interesting. But there needs to be that consistency of load. And if you want to see those adaptations by the end of a 4 to 6 week preseason, depending on what sport you're working in, it could be short, it could be a little bit longer, then they're going to need to start early. But obviously, we're kind of talking about it with the constraints of these are kind of gym-based exercises, right? But we also obviously are going to want them to be exposed to high-speed running and to have that acceleration and top-speed flight as well. And that obviously presents challenges. But then when you start thinking about strain and strain rates as well, then there's going to be exposure through there. The exact adaptations of the tendon tissues in response to sprint-based activities for the hamstrings particularly, we have absolutely no idea at the moment. There isn't anything in existence that tells us exactly what's going to happen from a geometric aura materials perspective. So I think it's definitely that combination that we're going to be looking for. But yeah, consistency of load. But then again, you can apply that to all sorts of exercises and adaptations.
I can imagine that it's tough to try to manage like tendon strain with sprinting, and trying to be able to quantify that is probably more difficult, especially if you don't have GPS tracking systems where you're looking at maybe workload over time and how to work in the tendon loading as well without maybe overdoing it would be.
What about the tendon, well, the in-office or, we'll call it acute look at tendon via ultrasound? What's your thought on the application of that to identify changes, pretty on the regular, as opposed to having to get an MRI and those type of things? In clinic ultrasound systems are all over the place now. So do you see that there being an implication to modify or to introduce those type of evaluations on the regular to see these type of changes or any type of change to the tendon?
They can be used. They I can't for the life of me remember the name of the author on the study, but there was one out over the last sort of year and a half that was looking at the use of 3D ultrasound, but also 2D ultrasound in terms of reliability of checking things like aponeurosis thickness or aponeurosis width. And that is feasible with a lot of practice. The issue with the aponeurosis is it's very thin in comparison to your free tendons. Like, it's really easy to scan a patella tendon. It's right there. It's really thick. It's superficial. But trying to get access to your deeper aponeuroses and get the right angle to be able to visualize the whole thing is not going to happen, right? It's too long. You're only ever going to get a snapshot. And it's really changeable along its length as well in terms of structure. So there's various images in those papers that you mentioned of ours that you can see exactly how different it is. You go from this free tendon that's fairly kind of elliptical into like a teardrop shape, which then spreads out into almost a flat line that then twists around. And, it's more complicated than I think people think when you have that typical image of like, oh, there's a tendon and then there's muscle fibers and then there's another tendon. It's like, in a simplistic form, absolutely. Not even close to the actual form.
Absolutely.
So I wouldn't be able to give you like, you should go 50% of the length of this and that's going to be representative of the whole thing, because it won't be. But I think if you're consistent with your measurements, then maybe there is the option to track things over time. We also, I should probably add this caveat in now as well. We don't know how important this is either. That's not something that has been done like prospectively to identify, is it actually a risk factor? We're basing it off the theory of like materials science, if it's smaller, which changes the stress, which changes a whole bunch of other things further down the line as well. So also bear that one in mind when we're picking and choosing. It's like, you could measure it. Do we know if it's important? Not especially. We think it might be.
Yeah.
What do you feel like are potentially the biggest risk factors for sustaining a hamstring injury?
Probably goes back to the consistency of load, and very much so on the exposure to those inciting mechanisms. So I think most people are pretty clued up on it, including high-speed running and including X cells, D cells. But also, depending on the sport you're working with, there's a whole bunch of other potential mechanisms in there as well. So, like I said, we did some work for rugby union looking at kicking mechanics and kicking-based injuries. And while most of them were anterior muscles, particularly rec fem, hamstrings were then the most commonly injured after that point. So, having still that progressive overload of making sure that you are getting exposed to kicking through your training and not just on a game day, that's still going to be important. There's been some more studies recently across soccer, both men's and women's, where they've looked at different mechanisms as well, and obviously highlighted kicking within that, and obviously different kick types feature within the sport, but then also the impact of things like indirect contact, so contact to the trunk, which then maybe throws them off while they're already in that running based motion, but maybe not at max velocity. Maybe that's where you're getting some of the slower type moderate velocity injuries, which are fairly substantial in number as well. And so obviously being able to train those things in as well. So basically any type of mechanism probably needs to be fed in, and that's going to be population specific. But again, like having a good gym-based program that is progressively overloaded, that includes a variety of different exercises, loading from both ends, all of those things I think are still important because they train the tissue. And if you're creating an adaptation that is potentially useful, then it's functional in some way, shape or form. I don't really care what the exercise looks like if it creates something that might be useful. But that's my 2 cents
Do you
worth,
feel
as it were.
like I know, of course, I live in ACL world, so there's all these prevention programs that have been, made up, created. People don't really do them. It's unsure if they work. We haven't really seen a decrease, and the number of ACLs actually seen more of an increase. I have not done a ton of research on hamstrings. Do you feel like there has been a reduction in the incidence, an increase, or sort of how do you see these? Like, it sounds like we sort of know what to do from a prevention standpoint, but do you feel like it's being implemented, or do you feel like it's still sort of this, I don't know, people know what to do potentially, but they're not doing it?
I think it is very much cohort specific. Like I know some clubs that do it religiously and feel that it works, and great, carry on. And then you also get some people that are like, no, we're not going to do those exercises. We're not going to do this. That doesn't work. We're not interested. And it filters down, right? And whether that comes from staff or whether that comes from within the playing group, again, kind of depends. But in some instances, I wonder how much of it is awareness as well, and being able to really dive into it and get these different mechanisms that maybe we couldn't have got 20 years ago. But one of the things I was looking at earlier was just out of interest to see what had happened with the effect of the pitch clock in Major League Baseball and their injury rates. And actually hamstrings have come down fairly substantially. So who knows why, whether it's to do with the training or whether it is to do with the pitch clock. But, I think things are going in the right direction, but we also do have that tendency to make people fitter, faster, stronger. And then is there some other magic element that we're missing that was the key to avoiding every injury under the sun? I don't know. But
if you figure that out, you'll be the richest person in the world, I'm sure.
Yep, I'm working on it.
I don't know how, I forget how recently at least, but like the BMAC grading, because in the past it was all grade 1, 2, 3. And people were obviously rightfully were like, no, it's more complicated than that. So then they created the ABC, which is what A is muscle, B is central tendon, and C is free tendon. Is that correct?
So A is they describe as like myofascial.
Okay, that's right.
B is then, oh, now you're testing me. I should have looked at this as well. It's been a while since I taught anyone this. B is at muscle tendon junction. C is intramuscular itself. So predominantly within the tendon tissue.
Okay. And is there one for free tendon?
Not specifically, no.
Okay.
Most of the time people ignore any free tendon ones with respect to grading for strains because there's no muscle fiber attachment directly into that free tendon. But realistically, you could have something that starts intramuscular tendon and that travels into free. So it's all attached, right? It's one continuous thing. But it doesn't have a specific one for free tendon. No.
Yeah. And I know they've done some research looking at injury rates and return to play times with that, and they've kind of been all over the place. Some say like intramuscular versus myotendinous junction, no difference. And then there's some pushback on, well, is it a longitudinal tear? Is it more of the, like how much of the percent is involved of the tendon or tear? Like how big is it? So you just get into like so much nuance and complexity. And I guess the question I always come back to is in clinic, unless you're at a professional club that can get MRIs or UTC or ultrasound all the time, you're just treating symptoms. Is that the end all? I mean, is that going to be the best approach?
I mean, if you don't have access, you don't have access, right? And everything we do is off function anyway, largely.
Right.
Like most people, when they return from a hamstring strain, are going to be at or close to functional resolution, but not necessarily anatomical structural resolution. There is evidence that you know, if you think about it from a tissue healing perspective, in your classics like inflammation, proliferation, remodeling is going to happen for many, many months afterwards, even if you're dealing with a muscle type strain. So I don't think that clearance should my opinion is that clearance should not be dictated purely by MRI if somebody is at that level of function, but we obviously still have to respect healing timescales a little bit because it is what it is. That's how tissue heals. So if there is the option to delay a little bit, then maybe that's useful. But yeah, you're right. Like you look at some of the studies that specify these return to play times, and they are completely all over the show because you might have somebody who is hideous on MRI, but actually their pain levels are quite low and they are really functional. And maybe some of that's just how they look structurally. Maybe it's not. Who knows? If you don't have access, you can't tell any of those things anyway. So you just kind of have to do your best. Like, are they back to strength? And obviously, again, we can then go down a debate about should you use the opposite limb in order to quantify that or not? Are they back up to the level of performance as well? If you have that data to compare to, but you know, expectations based on the population that they come from, some of that information exists, some of that is going to be best guess. But again, there's evidence that some people, when they, and I think this was actually across the NFL, that they return to play, or was it NCAA Div 1? One of those two. There's a paper that specifically looks at whether they achieve the same acceleration potential, whether they hit max velocity in their runs, and whether they're still covering the same sort of high speed distance. And even up to sort of 6 to 12 months post injury, there's still a substantial proportion of players that are not hitting that. So maybe that also plays into it a little bit as well, particularly when we start thinking about the re-injury side of things. How much of that you can actually recover in a small window as well, if you're aiming for a month as your return time. Again, up for debate massively. But I think that's where the early loading side of stuff comes in as well, and starting that off as soon as somebody is able to tolerate it. And I was having a discussion previously as well around this in terms of not specifically for loading the tendon, but what type of contraction should you be using in the early stages? And that debate has happened many, many times, right? You've got Jack Hickey's work about using early eccentrics and what that does in terms of recovery and future injury risk. But also, I think a lot of people forget that when you're performing an isometric, just because the whole muscle tendon unit isn't changing length does not mean that the muscle tissue isn't, and what the effect of that is on the aponeurosis as well. And that's why a lot of the tendon-based studies will use isometrics, and again, it could be mentioned earlier with that earlier study, if you put the muscle tendon unit into an elongated position and it's relaxed, your muscle fibers are always going to want to shorten. They're always going to want to increase those number of cross bridges. So you get this big pull, muscle shortens, tendon elongates, which is what strain is, right? It's a percentage of deformation. Mm-hmm. And so you have this high strain protocol just because you did an isometric, because your muscle tissue moved. And if your muscle tissue is contracting, then it tends to bulge as well in 3 dimensions. Your aponeurosis is directly attached to your muscle tissue, which means that that is also going to deform in 3 dimensions. So if you've got this longitudinal tear, is an isometric the best option? Because if you've got muscle bulging, then it's potentially going to pull that tear transversely. So I think there's a bit of a misconception sometimes around how that muscle tendon unit works and what we should and shouldn't be using and why things are safe or not safe, or all of that side of things as well. I think I've gone off on a massive tangent in comparison to the question.
No, that's
we
great.
love talking about rehab. You know, that's our favorite. I was working with our football team at UK this year, and one of the things I was looking into was, you know, like graded return to sport criteria for hamstring. And I didn't find much in regards to, you know, like there's an end stage kind of like, this is what we want you to be able to do, which is still probably not closely followed. But like for ACL, we have sort of phase, we need you to be able to do this before you can do this. And, you know, we have sort of phases throughout rehab where we're testing certain criteria like strength or hop testing. In regards to return to sport testing, are there certain things that you would like hold your hat on that somebody needs to be able to exhibit these certain qualities, whether that's strength, low levels of fear, etc., that they need to be able to do before they're, I say, more safe to be able to return kind of to full competition? Or
again, this is one of those, what's the magic combination questions, isn't it?
Yeah, that's hard. There isn't one, I'm sure, but I don't know if there's sort of a best guess that we might have, or Scott or Owen, if you guys have input on that as well.
I don't know that we do have a best guess. Because a lot of the guidelines that exist are based on opinion anyway. But I don't think anybody's specifically been able to investigate, if this factor is ticked off, then people are absolutely fine. But if this one is missed, then it's a problem. I do think fear is a big part of that, from the perspective of both exposure to all of those demands of running that we've already mentioned as a training modality and as a return to play guide as well. Like if somebody doesn't want to hit top speed because they're afraid, then should you be out on the pitch? Because at some point you're going to have to, and you're going to have to accelerate hard, or you're going to have to decelerate hard, and you're going to have to maybe chase down a winger or take that cut or whatever it happens to be. But you're going to get exposed to that. And if you're trying to back out of that, often that's when people end up in a worse situation and something else goes wrong instead. So I do think it's worth considering the sort of psych element and bring that into muscle tissue rehab, as well as things like, obviously it's been considered probably more from a ACL perspective with some of the papers and things like that. So yeah, those are the sorts of things that I think you definitely need to be in there. Strength gets resolved usually quite quickly, particularly maximum, or maximal strength rather. But also I think that, you know, going off into some of those other parameters in terms of like rate of force or rate of torque development is also going to be really important, because of the nature of some of these injuries where, you know, they do happen quickly. They do happen off that step or that cut, or on that one little perturbation of turning the head while they're on a curvy linear run, all of those things, right? So the speed at which they're able to achieve that strength is definitely going to be something that we have to resolve. It's no good just being able to produce force. You need to be able to produce it quickly. So I think that definitely needs feeding in. Obviously there's potential issues around some of the reliability of how you go about testing that and trying to get those and determine what your minimal detectable change is and all that kind of stuff for that side of things too. There's a whole lot of caveats and a whole lot of, but yeah.
Yep. Like I said, I looked into that and I was like, there's not a lot of concrete. And it seemed like, at least from the sports medicine team where I was at, it was very subjective, symptom-based progressions as opposed to more objective, like strength testing or things that were happening. So
yeah, there is some fed in along, like the Aspetar protocol.
Yeah.
They do have some objective measures within there. But again, how widely people utilize all of those is variable.
Also feel like too, depending on what sport, like you said, what sport you play, what position you play, what type of hamstring injury you sustain. Like if we've got a punter and they had an overstretch injury, or, you know, maybe there's different things that you need to look at with different people. And then it gets very, very nuanced on what you need to try to look at, I'm sure. So
Yeah.
That's the art rather than the science, though, right?
That is very true. It is an art.
Yep. And I guess you were mentioning rate of force, and I know Megan's doing a lot of looking into that with ACL World and the quad. With the hamstring, I mean, there was that weird debate for a while on is sprinting eccentric or isometric, like that back and forth for a while. But with rate of force development, conceivably sprinting, especially once you start pushing high speed or you're near max, is a high rate of force development of like mechanism and exposure. Is that enough for the hamstrings to be exposed to, in your opinion? Or obviously you have some change of direction drills or exposures you could also do, versus, you know, some people will have like Alex Natera will use a lot of force plate stuff and like drop catches and switching like that. I guess I'd be curious on your opinion on rate of force training, and is sprinting enough? Or do we need to cycle in other stuff or grade other stuff before we start doing some of that? Thoughts on that?
I think all of it should be progressive. Like, I'm not opposed to any of the things that you mentioned being included in people's programs. And I think obviously we do generally look at our sort of weight room based programs as being that stepping stone to get the tissue to be able to tolerate the load in order to then take them outside and actually sprint them. But realistically, like if you're going at a full, your actual maximal velocity, full sprint, there is nothing harder for that tissue that we like conceivably know of, right? Because of the speed at which it's happening, combined with the load. And like fundamentally, force is mass times acceleration, right? You move the limb faster, the force goes up. So simplistically, but you know. So yeah, like I think there's definitely scope for including all of those things in our gym-based programs to try and prepare that tissue as well as possible. But then it just has to be exposed to the thing. So like we said, whether it's sprinting, whether it's kicking, whatever it happens to be, if you don't do that and do it well and do it repeatedly and do it at maximal effort and intent, then you're probably not going to see some of the adaptations that you would like to. And people will be a little bit less prepared for what is coming.
Yeah, I will say at football, we've been playing around with hamstring RTD testing a little bit. There's not a lot out there on how to test it. It's difficult to set up. So we were doing it both on the Biodex in 30 degrees of knee flexion, just like rapid isometrics. We're hoping to test like a large proportion of the football players, one just to get some like preseason baseline norms, establish reliability, repeatability. We've done it with knee extension, which has been primarily a lot of my work with ACLs. I do acknowledge there are other muscles in the body that are important. So
same with hamstrings.
So we're playing around with that, and then we're also playing around with doing it on the Nord board prone, like in a hip extended position, and then obviously the Biodex, you're in a more hip flex position. And sort of looking at the differences in RTD between the two. So be interested to see how that works out, but it's difficult to test very large humans on some of this equipment in general. So, but I think if you can't probably do it isometrically well, the odds of you doing it dynamically in a sprint is very low. So I think probably testing it isometrically, if that's not good, you could be probably pretty sure it's not going to be good when they step out on the field. So
what do you think the angle has to do, the angle tested has to do with the transferring to sprinting? I think if you can do multi-angle isometrics, I think you'll get a better picture as opposed to just that one snapshot.
Yeah. So we did 30 in the literature. They say that's the angle at which most sprinting injuries occur. From a time perspective, it would take a really long time probably to do multi-angle because we're doing like 8 to 10 trials of one angle for both limbs for 2 different types of testing. So I think if you can find one angle that seems good.
What else you got to do, Meg? Come on. What else you got?
You're right. Nothing. I'm also finishing my PhD stuff, so you can probably empathize.
Oh yeah, so you're not snowed under with work at all. Yeah.
No, I've got all this free time to be.
Yeah. Have you thought about doing a second one? You could just tack on.
No.
Okay. All right.
I haven't, but I'll consider that for sure.
Okay.
I'm glad you directed that at Megan there, because I was like, me? Second one? Well,
She said, no, I've done all the steps. I'm
you're
ready to make some money, I'm
She's in the
sure.
middle of it, so
Yes.
what's another 4 years?
No
Whatever.
thanks.
Might as well be a orthopedic surgeon by this point, but it's fine.
Hey, Steph, where can people find you?
Socials wise, my Twitter and Instagram would both be Steph Laz _, and then I think I snagged Steph Laz on Blue Sky, although I'm still setting that up. But LinkedIn, I'm on as well. I'm pretty easy to track down with my name combination if you want to send me an email to my work accounts. If you're going to do any internet stalking, you'll be able to get hold of me there as well.
You're the only one.
I literally am. So it's quite straightforward.
Awesome.
So any of the above.
Awesome. Thank you for that.
Yeah. Any final take-home points that you want people to remember about the hamstring?
Don't get hung up on the exercise and do something. It's probably the bottom line.
Something greater than nothing. I love that.
This is what we spend 4 years of PhD to be able to tell people.
Yeah. Can I give you any specifics? No. But if you do something, it's better than doing absolutely nothing. But then it is, right, from a compliance perspective. There's no point in designing a world-leading injury prevention program if no one does it. So
yes,
get some load in.
Yeah.
Don't get hurt in the first place.
Also helps.
Yes.
Yeah.
That's true.
Don't get hurt. And if you're hurt, do something and don't do nothing. Got it.
Yep.
That's rehab in a nutshell right there.
Right.
Yeah. Try and do the something before you get injured as well, just to, hope
Yes.
for the best.
Yes. Absolutely. Excellent.
Easy.
Excellent. Yes. Well, Steph, thank you very much for joining us and taking time out of your day and dealing with Meg and her cat and Owen.
Cat? No,
Didn't your cat just walk into the room?
No, those are dogs.
Those are dogs?
Those are dogs.
Your dogs look like cats.
No, my cat looks like a dog.
Well, again, thanks for taking time out of your day. Meg, Owen, you have any last words?
No.
No,
No.
Yeah,
Just
no,
thank
no.
you for taking your time out of your weekend. Come chat with us.
No problem.
Really
Thanks
appreciate
for having me in.
We'll have to do this again.
Why not? Let's do it.
Awesome. Well, everyone, thanks again for joining us. Make sure you reach out to Steph, ask her loads of questions about the hamstring. And until next time, appreciate you guys. Bye.